to Community Conversations on COVID-19. I'm Dr. Bryan Williams, President of McCall College and the moderator of this series. McCall College is set in McCall, Idaho, and we offer meaningful post-secondary education for students of all ages. The motto of this particular series is Local Voices Addressing Local Issues. And our goal is to encourage vaccine participation by those who are hesitant to get the vaccine. In our county, Valley County, there are 10,000 residents. Approximately 3,000 of those residents will be hesitant to receive a COVID-19 vaccine. Now, each one hesitates for any number of reasons. Our series will attempt to answer the main points of concern with local, trusted sources of information. The freedom that we've been all talking about with this term herd immunity, and we're going to talk about that tonight, will only be achieved when we have participation with the hesitant population. It's a joy tonight to introduce a public health expert, and her name is Gina Pannell. Gina is the public health manager at Central District Health in the Division of Family and Clinic Services. She has a Master's of Public Health degree from Idaho State, and she's been in the field for 10 years, so we appreciate her experience tonight. She currently oversees the CDH's primary health clinics, and she's been a part of our local public health response efforts for COVID-19, and very much involved in the vaccine rollout for all the 4 counties in the CDH's jurisdiction. And those 4 counties are Ada, Boise, Elmore, and Valley. Thank you for joining us, Gina. We certainly appreciate you giving your time for us tonight.
Thank you for having me. I appreciate it.
Gina, the first question I have is just definitions. What's public health?
Sure. So public health is promoting and protecting the health of people and communities in a very large spectrum. It includes the places where people live, where they work, play, worship, learn, grow, all of the above. We, in most states, have a local public health department, and they're defined by different capacities, whether that's an individual county or multiple counties, whether they're run by the state or individual sort of regional approaches, which is how we are, how we function. We were established by Idaho Code about 50 years ago, and we have a local board of health. Our scope is very broad. To talk a little bit about some of the things we do, because some people just learned about us during COVID and they weren't aware of our existence, is, and honestly, that's when we do our job really well, is when we're doing it behind the scenes. And so some of those things that I'll talk about that is traditional to our public health department is related to environmental health. So we do things like restaurant inspections, food safety and sanitation trainings, childcare inspections. We have land development proposals that we review, and wastewater inspections, et cetera, sort of that environmental health component. Then we have a public health preparedness branch, and that's really the emergency planning, and we're protecting people from health hazards for excessive summer heat, winter temperatures, the flu, West Nile, COVID-19 would fall into that bucket. And then we have a health promotions division as well, and they facilitate things that are really prevention focused. So looking at upstream efforts, policy related activities. We oversee a regional behavioral health board. They offer tobacco cessation, a fit and fall proof, which is for seniors. So there's a lot of array of things that we do. And then our primary care clinics. So we have a family and clinic services division where we focus on individual client care, and that's reproductive health, immunizations, primary care. But in that division, we also have Parents as Teachers, which is a support program for families to be able to help children develop over time. And then an infant and early childhood mental health program to help with those really young families who are trying to connect, as well as our women, infant, and children's program. So it's a little bit of a mouthful, but we do have a broad scope of things that we do is to serve the community.
Gina, that sounds extraordinary. There has been concern that the budgets of public health have gone down over the years. Has that been the case in Idaho as well? Because you're doing so much how do you do it?
Yeah, I think as a nation, we've really divested in public health, and that's across the board. I can't honestly speak to our individual state and what we've done, but we have very tight purse strings. We get federal funding. We get some state funding from the state general funds. We get contributions from our counties. And so what we can't achieve as far as revenue from grants and those types of things, our counties do put up money to help support the functions that we offer. So we try to be pretty efficient because we don't have a lot of room. We don't have wiggle room. We try to just meet the directives that we have. We set fees and things, which also help when we're doing restaurant inspections. Like our patrons are expected to pay for that service to help fund us overall. So it's a changing environment, and we just try to adapt as best we can.
Oh, congratulations on trying to accomplish as much as you're doing, let alone a pandemic that now swamps your boat, I'm sure. What motivated you to train for public health? Do you have a bit of a story?
I really, in my professional career, was growing, and in the work that I was in prior to this, found it quite limited, and it was in recreation therapy. And I won't go into the details of that, but it was just very limited in the ability to impact health and long-term outcomes for folks. And so I knew that public health was a place where we get a variation in skill sets. We have a lot of influence in different sectors, whether it's in a hospital sector or a local health department, state health department. We can work on an individual programming level or in policy roles, crafting health policies for communities and states. And we really focus on health equity. And that's what drove me to it, is because we all want and work best and sort of function best in society when we feel good and we have the resources and the environments to allow us to do that. So that's what drove me to this role. And knowing now, I guess I never would have expected that pandemic would be one of those tick marks I could check off on a resume. Some of our internal staff probably did, but it's certainly been a great learning experience for all of us. And we feel very comfortable with how we were able to band together and respond to this. And we're small but mighty. I think we had a little over 100 staff members before this started, and we've increased a little bit for contact tracing, but other than that, we just all pivoted and went all in.
Wow. Well, we're in the middle of a pandemic, which is a pretty obvious statement, and we've been in it for a while now. So we're all putting in our first birthday of pandemic responses. What's the role of public health when we're in the middle of a pandemic, like we've seen with COVID-19?
Yeah, well, our local health department has been the center of response efforts for our local communities. There's certainly the state health department, Division of Public Health, Health and Welfare that have stepped up and filled their role as well. But our communities look to local expertise, local connections that they already have. And so we were in all areas of response, from our epidemiologists, who honestly are the epicenter of the knowledge for every single team member that is in our health department. They were a team of just 5 people before this started, and they've expanded their team up to about 35 folks to help with contact tracing. But the team itself remains really small. We only have a handful of epidemiologists. And so we have that department. Then we have a communications team that's all things COVID. When you talk about websites, guidance documents, media requests, social media, they are responding around the clock, trying to get those things managed. We have a logistics team that helps with trying to get, at the beginning of the pandemic, if you recall, there was some issues with PPE. The hospitals didn't have enough gowns and masks and gloves. And so they were helping get the resources where they needed to go. They help with the county emergency management support and then vaccine distribution. And then another sort of function of the health department was we created liaisons, and we knew that there was unique needs going to be needed for our rural counties. So every rural county has a liaison for schools, for daycares, for event planning, for healthcare, for vulnerable populations. And so we just tried to give each of those entities sort of an expert or someone to grow along with them to be able to have that point of contact to share. And, we just pulled in different directions and different capacities, trying to learn and support our communities in whatever way they might need it, in communities and or entities and or people. And in addition to a call center, I would say. So that's one of the things that I want to make sure that we know is out there. If no one has accessed it, it's a great place to get information, but people just want to talk to a person. As much as a website is helpful, sometimes you just want to hear it come out of somebody's mouth. And so standing that call center up from the first time the case was available, or we were made aware of the case here in Ada County, we have stood up this call center and just tried to keep up as best as possible with the inquiries. And it helps us guide sort of forthcoming communication and some of our planning as we hear about themes in the community about what is not being communicated or what the needs might be that we are overlooking.
Do you have access to that number now?
I do. Yeah, it's 321.
Would you like to tell us what that number is? And I'll put it on the screen when I have access to edit it.
You bet. It's 208-321-2222. It's really easy to remember.
Let's do it again.
Yep, 208-321-2222.
And when they call, what would they expect?
Well, they will get a list of options. Some people just were, I mean, I'm going to back up a little bit. It would depend on at what point in time you were going to call. So for a while there, it was really heavy on vaccine information. But right now, things have slowed down a little bit. They will get an actual human being directly to be able to answer questions, whether that's about, I think I've been exposed, what do I do? I want to get a vaccine, where can I go? Or I've gotten one dose of a vaccine, but I can't get the second dose because the provider doesn't have it. Or I'm traveling out of state. What's your recommendations? I mean, you name it, and we're answering those questions.
Excellent. Now, in many of our communities, and in particular McCall, we've had this new experience of having to wear masks.
Yes.
How did your organization interact with the city? McCall was very early last August, I think, in implementing a mask mandate for our community. Did you folks have relationship with our local staff, and then the county implemented it, and then the county took it off, and then McCall put it back on? As we went through the various recommendations of masks and distancing and those things, what was your role as you in interacting with our community?
Absolutely. So I was lucky enough to get invited to the Valley County Task Force, and it was a COVID task force originally designed to focus on economics and businesses, right? Like, because they were shut down and they were saying, how do we navigate through this and let them open safely? And so that was where I was plugged into that group. And what we quickly found is this group was capable and willing to take on a lot more. And you can't just address businesses without addressing masks, without addressing tourism, all these other things that came in place. And so I was quickly building relationships with the city manager in McCall, with Valley County, commissioners were on there. We had Chamber of Commerce, we had, you name it, local businesses. And so that group still consists and still exists as of today. And it was just, hey, Gina, can you present at city council? And can your director participate? We have these questions. Do you have sample resolutions? Guide us through this situation and this circumstance. What can we expect? And help us answer community questions that would maybe not come to us, but we're coming to city council members, right? They're trying to navigate that. And so I feel very comfortable, and we built a quick and strong relationship because it had to be that way. And it's maintained over time.
Oh, that's wonderful. Commissioner Hasbrook will be a guest of ours, I believe 3 weeks, and we'll be hearing from him directly. And I'm sure your work with him will be noted and appreciated, because that kind of input's crucial for good decisions. And any sort of comments on the mask issues that we're sort of fighting, or the distancing, or any of the other recommendations that have been part of this pandemic?
Nobody likes any of them, including myself. But I know, and we know, that they are effective. They are low cost as far as financial means, right? It doesn't take a lot. You can create your own mask, and they are essential. They help reduce the spread. They help slow the spread. They help keep yourself safe. They help keep your family safe. And, those were put in place, and we're in places in other countries where that behavior was maybe more normalized, but not in our country or in our state. So it was really challenging for people to sort of buy into the idea, because it was different. It was new. It was a social norm that we were trying to, make totally different. And I think over time, people have become more comfortable. There was a lot of pushback. I was a school liaison as well. And I remember getting tons of questions about how are our kids going to wear masks? And I thought, they're not going to be your biggest barrier. You just, demonstrate for children and teens and tell them why. And generally they do those things. But no one likes being told what to do. And at this point in time, we have an advisory in place. We don't have our order, but it still remains the same. Distancing and masking are critical. We have new variants that are coming our way. And so we know that those are going to help keep the cases low and help keeping our communities open. No one wants to move back into these other stages like we saw ourselves open and then sort of slowly close again. We don't want to be in that place. We've come too far. We've worked too hard. And vaccines are here too. So we're closer than we've been before.
Now I don't know if you saw today's paper at the Star News, but the Star News reported that City Council had dropped the mask mandate. Had you heard that?
Well, we had met as a task force today, and I know that they are meeting to reconvene in a week or so to reconsider the mask mandate. So I'm not sure where they'll end up landing. And the city of Boise just reinstated theirs. So we do have our advisory in place, which still gives the same recommendation behind it. So hopefully, I understand the pressures that most people are under when they have to make those types of decisions. So we stand by them and believe that the mask mandate is important. And as a backup, they have that advisory to help support the work they're trying to do.
I hope you won't mind this, but may I remind you what the day is? April 1st. The April Fool, as McCall's tradition is in our Star News, is always to have an April Fool headline or subheadline. And this year's was on City Council dropping the mask mandate.
Oh, man,
so
I thought
apologies for pulling the wool over your eyes for just a moment. That was sort of our community chuckle you got to be a part of, right there.
Oh, well, yeah, now I really feel like I can participate in all Valley counties.
And thank you for participating in that one. How successful have we been, and how successful has public health been in Idaho and in our region in fighting this pandemic?
It's a really tough question, and the answer will depend on who you ask. It's hard really for me to speak to the state as a whole. It's been handled so differently by every health district, and every health district has very different board members and very different legislators and sort of influencers, so to speak. But our core of the work has remained the same. We know what works best, whether it's in an order or just recommendations or guidance. So our Board of Health, their adoption of our recommendations was really good from the get-go. They knew, and luckily we have a great board, and they bought in and they understood the seriousness of what was about to happen or what was happening, and so that helped us significantly. And for Ada County to step up, and the city of Boise to step up, and the city of McCall to step up, there was a benefit to having everybody sort of on the same page, so to speak, if you can say that, in this type of environment. And then I think we had really good success with building relationships and using our credibility in the community. And they began to look for us for guidance. And so, I think the Valley County mask mandate that we had in place was there from August to February. So that's a pretty good chunk of time. And during the biggest peak when the hospitals were close to becoming in the crisis standards of care, I don't know how close, but they were closer than they'd ever been. And so those things are really important, and they only come by when you have credible people kind of giving you guidance and recommendations. And so I think our director said the other day to our entire team, he said, I wouldn't have done anything differently with all of the efforts that we have undertaken, because there's no way that we would have known to do anything different. And based on what we knew with the information we had, we did the best we could. And I believe his comments are absolutely true.
That's reassuring. And I think it's important to really, because this is new. Everything was so new, and the tracks we had to follow are from basically 1913. Is that when the Spanish flu was the last track in the sand? 1918. Thank you. And so thank you. Early on, there was real frustration in Valley County over trying to get community knowledge about what was happening for infections. And the community was really struggling because the only data we were getting were Valley County residents. And everybody knew that the guests that were coming and going from Valley County were also getting sick, but we didn't have any information on that. And there was a real sense that we were very, very vulnerable. How do you calculate those cases and those death rates in our region? And what can we do about this sort of struggle that we have when we're a resort community with an awful lot more people who might also be affected in a pandemic?
Yeah, I ran up against that barrier really quick with the task force, and there was some frustrations on their part that were very valid in their communication. And so we did our best to kind of for them to understand how and why we did our calculations. And some of it just has to do with the systems that we have in place. You talk about divesting in public health. You can guarantee we don't have the most up-to-date technology in place to be able to track things. So it was by county of residence, by place of residence is the information that we could get in our systems. And that's how that information was shared. And early on, when you look at, because this is a health outcome or a health disease, you don't want to give away information that may indicate who was infected, right? You want to protect them, and it's their health information specifically. And then also keeping in mind that this is a pandemic and it could be potentially infectious to other people. And so there was a threshold of population size that needed to be discussed about what was that threshold to be able to break it down by city, so that we could get to a place where individual cities would then be able to know their specific case counts. And we got to that place, and it's on our website. So you can look at Donley and McCall and Cascade and then outlying cities outside of there or areas outside of there. And so we had to have those conversations and make sure that we weren't disclosing, because there's some small towns out there. And if you put one and you can talk, up to the neighbor, you're going to be able to figure out who that is. And we want to protect their health and safety. So one of the ways that we do it for the countywide perspective, and part of that justification I'll back up, is because the level of risk, everyone wanted to know, like, what is my actual level of risk? And because of community transmission and because of the 48-hour period of contagion, we will never be able to give you your true level of risk. We just can give you the case counts. But regardless of if it's one case or 30 cases, you should be doing the same thing. You should be social distancing and masking of case. So one of the part of this question is the case rate. So the one we went to most often was the biweekly case rates, which we established for school category determination. And it's posted on our data tableau. And that looks at a 2-week average of daily cases calculated per 100,000. And that's by county. And they have different thresholds. Valley and I believe Valley County and Boise County have different thresholds because you're a little smaller than Elmore and Ada, because we wanted to, not have a school shut down or a community panic. Because if you have a family in Boise County, for example, with infections, then that could put them over the threshold, right? When it's just one family. So we wanted to make sure that we tried to account for some of that. And then a couple things about the death. People talk about the death rate or the mortality rate, and that's not information that we calculate or the state puts on their dashboard. When death rates are calculated, it's typically either the rate of death by the total population or the rate of death by the number of cases. And which we just didn't have that information. We did pull kind of an interim report in December, and I have the numbers here. And it was death by age group, because we know the level of risk goes up by age. And so at that point in time, for our entire district, it wasn't by necessarily Valley County. It was 1 in 7 if you were over the age of 80, and 1 in 20 would die if you were between 70 and 79, and 1 in 100 between 60 and 69. So we could just tell, and we knew based on what we were seeing nationally that the risk was much higher. The reason that the death rate, I think, in my opinion, wasn't really focused on is because people do exactly that. They focus on it. And they don't think about the morbidity and all of the other outcomes that are detrimental, these long-term consequences of COVID. And there's no way to ever capture that because it shows up in a variety of different ways. And so that's just not something that our team felt would add any value, and maybe possibly cause more confusion, and probably couldn't do it because we didn't have the data when it comes to that. Coroners were backed up. Like, I don't know that there would have been real accuracy in any of that at the time where cases were really, really high.
Do you sense that the variants that are coming now, whether from the UK or from Brazil, are going to force us to look at the younger populations as we're seeming to experience in the rest of the country?
Yeah, that's the trend that is happening. Part of that is because the older population is vaccinated, so they're being protected, and it's moving to the unvaccinated. And so I don't know what we're seeing in our local hospital systems. Unfortunately, I didn't check into that before this, but I think we know that other states and other countries have experienced just that. These younger folks are filling up their hospital systems and becoming more impacted by, versus long-term cares who've already been vaccinated, and the 65 and up population who was the most at risk.
Thank you. One of the terms that you were using was contact tracing. Could you help us understand that concept and sort of help define it? And sort of the dilemma is we sort of always assume all the resources go to Ada County. Was there actually contact tracing in Valley County? And what did that look like?
Yeah, you bet. So contact tracing involves identifying an infected case and then who was exposed as a result of that and their level of risk. So we would get a positive test result at the health department, and our team would contact that positive case and say, we received your positive result. We're here to talk to you about who has been within 6 feet for more than 15 minutes the last 14 days, because that's when someone could possibly been exposed. And typically those individuals had already started thinking about that because their healthcare provider wouldn't have notified them of their case. And so they start, maybe feeling anxious about, oh, I really need to start recalling what happened and who I was with, et cetera. So we look for them to help share that contact information of who those close contacts were so that we could contact those folks and tell them about signs and symptoms, what to look for, how to monitor, how they should be quarantining, and talk through isolation and quarantine. Some of our team was able to support with resources. If you're an individual person living alone, self-quarantining, but you need groceries, what do you do? So with the resources that we could point them to, and we tried to do that. And as far as our ability to support our outlying counties, we get lab reports, and as I mentioned, by county of residence. So we could prioritize our rural counties, and they were prioritized the entire time because the cases were smaller. So we knew we could move them up in sort of, so schools got prioritized, rural long-term care centers, people we knew were high risk, and rural counties in there as well, because we knew that, it spreads like fire in any setting, but in rural counties, it can really go quickly. So yeah, we absolutely offered that. But it was here from our central office. And some of our other partners, like schools, they started doing their own contact tracing. So they would just consult with us and help us understand that. So there was some alleviation in some entities like schools to be able to free up some of our staff. But there was a point in time when contact tracing wasn't happening for almost anyone unless you were super high risk. When cases were 1,000, 2,000 per week, there's no way. We didn't have the staff. It was almost no point in calling because, one, maybe they wouldn't answer, or by the time you got the report, they're a third of the way or 2/3 of the way their isolation period. So it was really challenging when cases were high. But Valley County, specifically to your question, didn't get less contact tracing than anyone else.
So are you comfortable now let's staying with Valley County, are you comfortable now that in any case that is happening in Valley County, there's reasonable contact tracing going on?
It's absolutely happening in all 4 of our counties, including Valley, because we're at a case level or a threshold that is manageable.
That's wonderful news. Another term that we've talked about tonight that I think is one of the national terms that everybody is struggling with is the term herd immunity. So sort of define it to the best of your ability, and I know there's 1,000 different ways to define it. But how do you estimate we could achieve whatever this term means in our region? What's it mean?
Yeah, so herd immunity is a term or phrase that looks at having more people vaccinated or immune. So that could be through vaccination or actual infection. We prefer through vaccination because you don't have the consequences of infection. So enough of those people are immune to the disease that they can protect those who can't or are unable to get the vaccine. So you have some people that are immunocompromised, and there's a few folks out there that have some risk factors that indicate that they shouldn't. But for the most part, anyone over the age of 18 or 16 with Pfizer, I should say, is eligible and should be vaccinated, and should learn about the vaccine. And we'll talk about that in a little bit. But For example, our kids, though, they can't. There is no vaccine that's available for them at this time, and so that's a population that will be protected as adults become vaccinated, because it's just like a layer of, I don't know, when you're cold, you add a t-shirt and then a long sleeve and then a coat and then a blanket. Like, you're just adding more and more protection for those folks that are, the cold ones in the middle who maybe can't or are unable to get that vaccine. So the question has come to us, when will we reach herd immunity? Can we reach herd immunity? And we know that as of now, everyone 16 and over in Idaho can be vaccinated. But we're looking at estimates of up to 80% of our population or so. It really depends on who you ask, needs to be immune in order to reach that herd immunity. So that would mean essentially everyone in the population over the age of 16 needs to either had the virus or receive the vaccine. And we are not there. We know our take-up rates are not there. And the other kind of consideration, I would say, is that herd immunity, we may fluctuate in and out of herd immunity over the course of the years, right? Where we feel comfortable that people have been vaccinated or, hopefully not infected, but if that's how they're immune, and then either there'll be a second round likely of a new vaccine where we have to have a booster, or, it's undetermined what that will look like. But this is going to be an ongoing target that we need to try to reach. And it will be impacted by county lines, city lines, international lines, because if people coming to us are not vaccinated, then that lessens our percentage of herd immunity over time. So we need to build up that percentage as best we can in our local communities so that we can have a barrier for when people do visit us who are not vaccinated, they don't start an outbreak or kind of flip-flop us back to a situation that we don't want to be in.
Does public health connect herd immunity to wearing the mask, so that we can only get rid of the mask if we get herd immunity? Are those connected, or is there another criteria you would use to say when you would cease to recommend using a mask?
That is an excellent question, and I don't have a great answer for you. It makes, to me, really good sense because it is a level of protection that prevents the disease from entering or exiting a body without being immune. So I think that is part of probably the calculation, but I don't know that we've sat down and said, okay, we need to meet X, Y, and Z criteria to be able to remove our mask advisory. Because at this time, we also have variants that are circulating that we're just now learning that the current vaccines are being effective for, but before now, we didn't know that. So I think, in our view, masks are going to be around for quite a while, whether that's, if you're vaccinated, you don't need to wear them, or if you're not vaccinated, we highly recommend you wear them. I mean, I think that's still to be determined.
Oh, we had a wonderful epidemiologist for our first two conversations, and that was Dr. Mike Weiss. And he wanted me to ask you this question. Now, I'm not sure if it's a duplication or not, but I'm going to ask it and let you sort of sort this out. At what point do you assume minimum spread of the virus in our region?
Yeah, it's also an excellent question. So I went to our epidemiologist for this. And she pointed to the CDC, and they define low community spread as 2 to 3 cases per 100,000 population per week. So she said, to put this into context, the past week, Valley County's weekly case rate was 35 cases per 100,000. So we're nowhere near that 2 to 3 cases, but we're talking very rare cases, not weekly, very well managed. And so I don't know when we will get to that point, but at that to me, if we can reach that, maybe means masks can be relaxed, maybe things can open up a little more liberally, so to speak, but that is how they define low community spread, which that's hardly a sneeze, pardon the pun, but it's very.
Ouch. Ada and Valley counties, as well as 2 other counties, are part of the Central Health Board. What are the advantages and disadvantages of linkage between an urban county and a county like Valley, whether you're rural or whether you're resort?
Yeah. So the advantages from where we're sitting is we as a health department support our 4 counties the same. And so we are looking that our central resources are allocated to support our communities in all of their uniqueness. And so the benefit of being part of a board with Ada County is we get We have more staff than a lot of health districts because we get more funding from Ada County because they're a larger portion of the population, et cetera. So they allow us to be able to have maybe more resources, but honestly, per population, it might equate. But we have also the ability, which this just came to mind, is people in public health professions, not all, but some of them like to live in counties such as Ada, where there's lots of things to do, et cetera. So sometimes that attracts higher quality candidates and higher, credible people. Not always, because there's very credible people in our rural counties, but that is one benefit of being part of a board that has a larger county attached to it. I would say some of the disadvantages are that Valley County is so well sought out as far as recreation and things to do that you attract a lot of travelers, and you also have a lot of second homeowners that are up there in likely from Ada County, not all of them. And so if we are a hotspot, but Valley County is not, then we're bringing our hotspot to you per the conversation that we had earlier. And so that would, I would say, would be a disadvantage. And then I think that there's also it makes the risk of infection higher. I think that the rural counties sometimes have less healthcare infrastructure and maybe no ICU beds, or, if you have a healthcare team, you don't have a big bench, so to speak, to be able to sub in if your only doctor is sick or your nurse is out because they're either exposed or in quarantine or have COVID themselves. So I think that we are very grateful to have these sort of 3 rural counties along with Ada, because it's a nice mix and we get to see the different needs from the different counties and how we can support them in a unique way.
Thank you. It sort of begins a conversation I'd like to have. My assumption is that public health is classically defined between 2 entities, and that's an urban public health versus a rural public health. My question is, McCall's different. Should we have a resort public health? Let me just do a bit of background. As I recall, one of the very earliest hotspots in the pandemic was a ski resort in the Alps. And the wave that went through Italy really came from that ski resort as everybody came together in a resort area and then dispersed throughout Europe. I think we saw the same thing in Idaho. And so I'm wondering if we really shouldn't have some work on what a resort community is and what a resort community, what struggles we're going to have, but possibly even what advantages we could have if we put more resources into our resort communities for public health. Almost a canary in the mine is what a resort community might be. Can you give me any feedback on that difference between rural, city, and now resort?
Yeah, well, I did mention, and you indicated too, some of the risks that you have travelers left and right coming to you from all across the globe, across state lines, county lines. And the perception, I think, for some rural counties, non-resort, is that we're isolated and immune. Like, we're up here, we're in the mountains, we're totally fine. Things are going to be great. And then you have this flood of folks that come because, one, they don't either like the city rules or they don't want to be in the hot spot, so they want to come up there. So I do think it's a unique idea about the sort of resort public health. What comes to mind is when I think about the individual uniqueness of communities in general. And I won't bucket you along. I mean, you're almost like your own vulnerable population, so to speak, because you have this unique feature. You have these travel restrictions, or not restrictions. You have these travelers who come to you. You have second homeowners. You have maybe a booming economy that completely relies on tourism. You have these types of unique features. And then maybe in another situation, a vulnerable population, such as our migrant population, they have X, Y, and Z vulnerabilities and unique features. And so I think that putting them in sort of a subset or a pocket of whether it's rural or urban, I think in this case it would be rural, but how can you identify those risk factors and some of the advantages that you mentioned that could be leveraged? And I think if we had time to plan and the resources to plan for a pandemic in a rural county, in the city, and in a migrant population and in a resort community, then we would have been maybe, well, likely better prepared to do that, but it just didn't turn out that way. So I do think there are lessons learned from the resort communities, because I know I remember talking to Dr. Irvin up in McCall, because he's in the Valley County Task Force, and he's talking about resort communities all over. And you'll notice, and we just talked about today, there are multiple ski resorts in Canada and other places that have shut down as of the last few days because of outbreaks. And so there is something unique there. And it would take some time and some dialogue and some local expertise to kind of run through that. But we would welcome additional public health resources to support something like that. I think it's important.
So does it make sense that your resort communities are your early warning system? If there was, for example, wastewater evaluation ongoing from now for eternity of your resort communities, would that not give us a sense of an early warning system that could tell us what's going on in the entire area?
Yeah, that's a good point. It possibly could do that. I think one of the other things that resort towns do, and they've demonstrated, is the lag of the peaks of infection. So they lag behind. If Ada County started going down, Valley County was still up here, because what you have is travelers coming and exposing locals who then don't get infected until 14 days later, up to 14 days later. So then the cases continue to elevate, while other cases that maybe brought the infection up, possibly, I'm not making a causation that happened, but we know that sometimes it did. And so we did see that in some questions from the Valley County Task Force about that, because then they would expose their coworkers and family without necessarily knowing. And so I think that they get the further end of it as far as duration of infection, and they possibly could be an early indicator of what we're seeing in the community.
Well, travel is an essential part of our community, and we not only receive travelers, we have a highly mobile community ourselves who are often traveling. And I'm just wondering if you could update us on any of the recommendations, or because we talked about the 14-day, and we've been seeing some people bring it down to 10, some people bringing it down lower. Where are we right now when it comes to travel and the recommendations of the Central District Health?
Yeah, so I looked to the CDC for this, because I think we would just default to what they're recommending, and they are just more robust in their map internationally, and we never know where people are traveling. Is it to Oregon, or I don't know, Italy? So one of the things that they do is a really good job of the recommendations vary by destination. So they have categories of, I think, 1 through 4, and category 4 is we do not recommend. We recommend you avoid this place at all costs. And then they'll move up in their levels. Like, we recommend you go here if it's for non-essential travel. If you need to travel here for work, etc., then that's okay. A couple things that I just learned this evening, actually, was they recommend that if you do travel outside of your own local area or across state lines, possibly, and you're with people outside of your own family, or you're on an airplane, or you have sort of larger risk exposures with people that you're not normally with, is that you get tested 3 to 5 days when you return, to see how you're doing, and then to isolate for at least 7 days, because people tend in general to develop symptoms between 5 and 7 days. Not always, it can be up to 14, but more people than not do that. And so that 7 days allows, and the test allows you to kind of feel a little more comfortable with where you're at, try to mask and social distance as much as possible. And for people who don't want to be tested, or who choose not to be tested, or don't have access to tests, the recommendation is to isolate for 10 days and then make sure you don't have symptoms, and just monitor yourself, and then kind of go back to, your pre-quarantining life or pre-isolation life.
I appreciate that. Thank you for updating us. What issues in our region have created the hesitancy that we're focused on tonight in getting a vaccine? And how would you recommend that we address those issues?
Yeah, so I think I wanted to start by kind of defining what vaccine hesitancy means. I think that's being thrown around a lot these days, and you've done that on some of your other learning sessions, but it's really the attitudes and behaviors where people are cautious, or choosing not to, or who are refusing to, or delay, right? So they're just not at the place where they're willing to make that decision. And so that is something that we are well aware of, and it will impact our ability to reach herd immunity, or to if you don't want to use that term, our ability to continue to go back to normal, because that's essentially what we're after here. And I think some of the things that we hear that are concerns from people is the rapidness of the vaccine compared to the traditional timeline. So when you look back historically, 10 to 15 years is what it can take. But what I think is the remedy, and I'll kind of talk through that when I answer this question, is really education and information from credible sources. So I know that there are phases that are part of a vaccine trial, and there's 3 phases, and it's for safety and development, and none of those were skipped. In this circumstance, we just had some infrastructure that was in place that allowed us to expedite some of the development, and we also overlapped, I didn't invent a vaccine, they overlapped some of the phases to expedite that. And it starts with laboratory tests for animals and in cell studies to see if we can put that into effectively into people, and then looking at testing for the safety in the dosage in a very small group, usually 10 to 50, and they're looking for adverse events. Once that gets through, you're looking to expand to safety trials where you have a couple more hundred and you're testing the dosage. And then you have the phase 3, which is that large scale, really efficacy test, and you're monitoring for adverse events and outcomes. So all of the things that happen typically in a vaccine development stage and study phase happened just much more rapidly because they overlap them, because we were in such a dire need to get this managed and a resolution. So we've been using non-pharmaceutical interventions, and that's what you call a mask or distancing. And so there's a pharmaceutical intervention that people can get, and it's easy and it's long-term, right? And so that was what we were after. So that's one of the things that I know that our team hears about. And I think one of the other things that isn't really mentioned, and I sort of just situationally know this, I don't think it's necessarily related to public health, is we have private and government entities working together. We have private entities who would normally be competitors who are just trying to say, how can we help each other? And that has never happened. I mean, when you think about just trying to get to solutions in our country, it's very capitalistic driven, and I need to do this for my entity and my business. And so to see that, I believe, had some influence in our ability to get this done and rolled out in a rapid fashion. A couple of the other things I'll talk on are the EUA, so the Emergency Use Authorization. So some people are concerned that it's only EUA and not fully approved by the FDA. So they're just saying, hey, you know what, I'm going to get it, but I'm not going to go until I know that the FDA has given the formal approval. And I just saw that Pfizer's looking to apply for that. So who knows how long that will take, but that is one consideration. And so those people they really truly are hesitant. They're not refusing. They want to make sure that it's as safe as possible. And then a few things that I know our medical director has mentioned is the mRNA. So it's not, the technology is new, but not unknown. And so it's actually been studied for more than a decade, but it's new to us as far as having it come into our bodies. And so people are just concerned about what that means, and it does not alter the DNA. So just learning about that and well-versing yourself in the process of an mRNA and how it works, I think is really helpful. And then a few last things I'll mention for the hesitancy that we hear is that that they're going to get COVID from the vaccine, which is not true. It's not a live virus, so it's not going to make you sick. And you actually build up immunity versus getting an infection, when it gives you immunity, but it also could potentially give you the long-term side effects or the impacts from the health outcomes from the infection. And then a couple that are less prevalent maybe in our state is the belief that maybe there's some distrust for the medical and healthcare profession because of some previous historical trauma, so to speak. So you have the Tuskegee experiment, right, where that was something related to syphilis, where the Black men and African-American men were not treated humanely. So that's part of it. We don't have a big African-American population here in Idaho, but we hear about that a little bit. And then I think one thing that's new to us that came to mind is that the belief that other people were a priority. So maybe they thought, well, I'm going to get the vaccine, but I want to wait because I think I think the 45 and older with one medical condition should go first. And so now that it's opened up, we're maybe, sort of crossing our fingers, thinking more people will be willing, who are kind of holding off because supply was such an issue.
Oh, those are excellent. Those are excellent. Thank you for taking us through that. What long-term public health issues do you sense that COVID-19 has brought to our community? And I'm sort of thinking about we've reduced the incidence of cold and flu to much lower levels. And clearly the masks have had something to do with that. And you see other countries, particularly Asian countries, where masks are almost routine when they go outside. And that was before COVID. And so that's one of the areas that I've been thinking about. But I'm wondering, as you look into your crystal ball, what's COVID done to public health into the future?
Yeah, so when I look at this question, I think about the negative impacts. So I'll start there, because I do think that there's some likely serious mental and behavioral health issues that we're going to see as a result of this, from the stressors of just dramatic life change, job loss, isolation, loss of family, the trauma that some people have experienced in losing a loved one. I mean, those things are long term and have implications. Alongside that, we've seen an uptick in substance and alcohol abuse and overdoses as a result of just not being able to handle those stressors and looking for things that are accessible. And unfortunately, I think that will be some of the long-term things that we're trying to deal with. And as the school liaison, I know very well from superintendents and administrators that learning loss for kids who are not in the classroom is very real. And these are really early stages of development for especially some of these kindergarten, early age elementary students. And so how are we going to pick up that gap? How are we going to be able to sort of mend that hole in the social interaction, the lack of that was part of being not only education wise, but these what I think a lot of families maybe or the public learned about, or even schools in general, whether they knew it explicitly or not, is you are a place of learning, but you're a place of nutrition, you're a place of safety, you're a place of a caring adult, you're a place of counseling. And so to have that taken away from kiddos is, I think, one of the hardest things that we will that's going to be years of damage where we have to keep up and catch up with some of the trauma caused from being in maybe an unsafe home, as well as learning loss. And how do we get these other kiddos up to speed who maybe didn't have technology, right? That they didn't have internet access. So, and then a few other things, I think just delay in healthcare, people not willing to go into a healthcare setting because they weren't comfortable or they couldn't get an appointment. So that could be pediatric care, it could be adult care. And then there's some nutrition concerns. We've heard, I don't know if you've heard, but there's a lot of stories rambling out there about the weight gain, the COVID weight gain, like the freshman 15. But it's, yeah. So I think that's really something that we'll look to. I like that you brought up some of the positive light. I think that what public health has brought to us is the reduction in cold and flu season. I think one of the things too is the ability to connect with some of these rural counties in this type of fashion, where maybe we wouldn't have been able to do that before, where they were maybe hesitant or unable to get the resources. But I know there will be future funding coming for cities and counties to be able to put up this type of infrastructure to have people connect, even if it's for healthcare or to connect with family members, et cetera. So I think that's one thing it did teach us. But unfortunately, I apologize, I didn't really think about all the good public health outcomes that were as a result of this, other than the last one I can say is just the relationship that we as a local public health department have built with so many partners. And I think that there's some long-term positive programs that will come from that to help solve some of the issues that we know will come about.
Gina, this has been wonderful. And we so appreciate what you've done. I'd like for you to sort of summarize for us now our target audience that we're trying to talk to are those that are hesitant to the vaccine. And whatever you say might be something that they would share with someone else in their family who may not have heard our conversation tonight. What would you like to say as just a final summary to our vaccine hesitant community?
Yeah, I can speak to why I got vaccinated briefly, and I want my life back. I want things, I think everyone, if they could wish for, January of 2019 where things were normal, would strive for that. And herd immunity and vaccinations and masking, those are the things that are going to get us there. I know it feels like it takes a long time, and it has taken a long time, but in the spectrum of life, a year, 2 years is really not that long when you think about a lifetime. And I know that it's really important that's one reason is I want my life back. I want to be protected, but I have a elderly mom. I have older family members that I want to keep protected. I want my kids back in school to be able to function and coach and carry our community through a pandemic and homeschool my children at the same time is incredibly challenging. And so we can't do that to families who really want to go back out there and who know that the best place for kids is to be in a school setting. That's the best place they're going to be educated for most kids. And so those are the reasons that I do it. I think that it's important for people to know that it is safe. It has been proven effective. There wasn't any steps skipped. I think if anything, that is what people can take away from this, is that there are multiple quality assurance measures in place to make sure that this is going to roll out as best and safely as possible. And that's been done.
Oh, that's wonderful. Thank you. And if I could invite you to stay on for just a few minutes after we've closed off our YouTube live, but I'd invite you at this time to turn your camera off.
Yeah, thanks.
Thanks. And so thank you, Gina, for a wonderful conversation. We are so appreciative of you taking your time and sharing with Valley County and our region on what is happening. I would invite you to come back next week. We have a wonderful guest coming, and that will be Kevin Ellis. He's a PharmD who is at Albertsons Save-On Pharmacy. And he'll be talking about vaccines and vaccination. And Gina was able to introduce you to some of the ideas that are so important to vaccines and vaccination. And Kevin will be building on that. He's one of those local trusted sources. There people go for information for their pharmaceuticals and now their vaccines. And so I know you'll want to hear his voice on what he's thinking about the various vaccines, the vaccinations, the side effects that people are talking about, how he's counseling people. Those will all be questions that we will be inviting him to help us with and to answer. So I know you'll look forward to next Thursday night at 7 o'clock when our community conversations on COVID continues. Thanks so much.